Welcome to the United Leukodystrophy Foundation presents MLD, presented by Dr. Joshua Bonkowski and Dr. Nicole Wolf.
So, good morning, everybody. I'm Josh Bonkowski. I'll be leading off our discussion today, and then after I present, my colleague Dr. Nicole Wolf will be presenting with her insights and greater depth of knowledge than me. So I'll just kind of start off the simple stuff, and then we'll go to and then we'll turn to Dr. Wolf. So, and then I apologize at the end of the discussion today. I do have to run to another meeting. At least I have to run virtually. So I apologize if I can't get to all the questions today. So our discussion topic today is on metachromatic leukodystrophy. So just real quickly, for folks, a leukodystrophy is a genetic disease. Then it can kind of take different forms. One is where the white matter doesn't form correctly. A second is if the white matter doesn't form at all. And then a third is if there's loss or destruction of white matter that's already there. So we've had data now for about 10 years on how frequent leukodystrophies are in general. So from a publication back in 2010, we know that it affects about 1 in 7,000 live births. And then there's new data coming out this year from our group as well as from, I think, a group at CHOP that the incidence might be even higher, closer to 1 in 4,000 live births. Leukodystrophies are very severe. Almost half of the kids never able to walk. There's a lot of financial burden on hospitals and on families. And then unfortunately for many children and adults, there's increased risk of death. So almost a 30% mortality by the age of 8. So white matter comes from, in the word leuko, comes from the Greek word for white. And the white matter is composed largely of something called myelin, which provides the insulation for axons, which are the parts of the nerve cells that send signals from one part of the brain to another. So myelin development begins before you're even born, so in the second half of gestation. And multiple pieces of myelin have to kind of form together to cover the axons. And so one cell called an oligodendrocyte that forms the white matter is responsible often for providing the covering for up to 50 different axons. So you can see that if one oligodendrocyte's not working, you can affect a lot of different parts of the nervous system. Let's make sure oops, I seem to have skipped here, sorry. So we'll be focusing today on metachromatic leukodystrophy, which is one of the lysosomal leukodystrophies, and I'll talk about lysosomes in a minute. So some other diseases in this category include something called Krabbe disease or globoid cell leukodystrophy. And the testing in general for metachromatic leukodystrophy and other lysosomal leukodystrophies is to send something called leukocyte lysosomal enzymes, and that's a blood test. So the lysosome is part of the cell. It's actually what's called an organelle. It's inside the cell, and it's responsible for metabolizing or digesting different parts of cellular metabolism. And so you can imagine it's a little bit like your local trash company. If they stop taking out the trash, you get more and more trash building outside your house. And so the same with the lysosome. If you don't get the lysosome working correctly, more and more toxic materials can build up inside the cell and then start to damage the cell. And so MLD, metachromatic leukodystrophy, is caused by a problem with a lysosomal enzyme called aryl sulfatase A, or ARSA. And so the testing, as we mentioned before, we would send a test, a biochemical test, a blood test for leukocyte lysosomal enzymes. And then almost always you also want to send a genetic test for the ARSA gene to prove that there's a mutation or problem in that gene. In addition to problems affecting the brain, there's often problems that you can test for in the peripheral nervous system. And so you can do a test called an EMG or NCV, that's a nerve conduction velocity testing. And a lot of times you can see abnormalities with nerve conduction velocity testing as well. So one of the characteristics things to do with the diagnosis is to do an MRI of the brain for MLD. And so in general, the MRI of the brain is diffuse, meaning it's not just in one area. And it also is symmetric, meaning it's affecting both sides of the brain. And then classically, it starts in the back part of the brain. So if on this MRI, let's see if I can make you can see here, this is the abnormal white matter back here. And you can see it's on both this side and this side, so it's symmetric. And it's diffuse, meaning that it's not just in one little tiny area, it's like this whole area back here. And finally, this is the back part of the brain, and so that's what we mean by the posterior onset. So there's pretty good data now that the frequency of how often it occurs at birth is about 1 in 40,000 live births. So in a state like Utah, where I work, we have about 50,000 births a year. And so that means that there's one child maybe born a year who is at risk for this condition. It's present across all races and ethnicities, so it doesn't matter if you're Caucasian or Hispanic or Black. It's across all these groups. There are some populations that have higher incidences. So for example, the Native American population in northern Arizona has a higher incidence. There's also some groups in Alaska or in Eastern Europe that have higher incidences, but the general prevalence, or general incidence, excuse me, is about 1 in 40,000 live births. It's what's called a autosomal recessive disease, so it's usually caused by 2 mutations in the gene, with 1 mutation coming from each parent. So you have to have the presence of both mutations to cause disease. There's also a different gene that can rarely cause what's also thought of as MLD, something called the PSAP gene, or Saposin B. That gene doesn't have a treatment, and so that's why it's important when the diagnosis is being considered or thought of that genetic testing is done, because the treatment's really different if it's an ARSA gene mutation versus this other type. So that's very important to be aware of. So there's different forms of MLD based on the age that it occurs. And so the most common form is what's called the late infantile form that affects about 55% of patients, usually in the first 1 to 3 years of life. And it unfortunately has a fast disease progression and can proceed towards death within 2 to 10 years. There's a form called the juvenile form, which is about 25% of patients, and disease progression is slower, usually over 10 to 20 years. And then the adult form, about 20% of patients, and the disease progression is slower, more over 20 to 30 years. All forms, as you can see, have progressive worsening, and they lead towards more disability and eventually death. And it's because that, as we were talking about, this kind of biochemical problem in the lysosome, and this toxic substance called sulfatides builds up in the cells. So again, just to go back to diagnosis, so the blood test is something called the leukocyte lysosomal enzyme testing. It looks for aryl sulfatase activity. And then after that, if that comes back as abnormal, you would also want to do confirmatory studies. One confirmatory test is a urine test called urine sulfatides. The other test is the genetic test, which you almost always want to get regardless. However, the genetic test is a little bit complicated because for this one gene, there's more than 200 different mutations known, and then I'd say every few months there's more mutations being found that cause the disease. On the lower right-hand part of your screen, you can see the biochemical pathway. It's a little bit complicated, but these are some different leukodystrophies we all may have heard of, like Krabbe disease or Gaucher's or Tay-Sachs. But this is where the problem with metachromatic leukodystrophy occurs, when there's a step going from a sulfatide to this compound called galactosebroside, and this step gets messed up, and so there's more and more sulfatides accumulating. So this next picture is kind of a complicated picture showing all the different kinds of mutations in the gene. So this top pie graph just shows the different kind of genetic mutations. They each have different names, like a missense mutation or a frame shift. And then here are the different mutations that are found, like the exact molecular change. But then at the bottom is a diagram of the ARSA gene. And each of these big red boxes is a part of the gene with the spaces between the different parts of the gene. And this list on top of each box is all the different mutations that have been found inside that part of the gene. So you can see it's really complicated and a lot of different mutations that can cause MLD. So at this point, and Dr. Wolf is going to talk about this in great, much more informed and intelligent detail, but at this point, the only treatment for MLD is something called a bone marrow transplant or hematopoietic stem cell transplant. It only works if the disease is caught early enough prior to many symptoms or neurologic problems occurring. Even even if someone healthy gets a bone marrow transplant, there is a risk of mortality, of death from the bone marrow transplant. So it's not a trivial process. And even with the transplant, the long-term outcomes aren't perfect. The disease still progresses. And so there's problems with that, with the transplant. So it's a complicated process, how it works. We think the thought historically has been that the enzymes of the good cells that you put into the body are somehow moving to the bad cells. That's this concept called cross-correction, although as Dr. Wolf will talk about, that concept may not be correct, or there's a lot of data now suggesting that that's not really how it works. The other really important thing about bone marrow transplant is the most common form of MLD, the late infantile form. Bone marrow transplant does not work, at least the historical form of bone marrow transplant that we've used. And so for the most common form of MLD, we haven't had a treatment that can help people be better. And this is just a picture kind of illustrating the idea of cross-correction, where the enzymes from a good cell come across and go into the cell that's missing the enzyme. But again, as Dr. Wolf's going to talk about, and this is actually a picture of her paper, which I'll be really interested to hear more about in the second half of today's discussion. So these are pictures from Dr. Groschel in Germany, looking at what happened after transplant. And so it's become clear compared to 10 or 20 years ago that transplant does not cure everything. So the first thing is on the left-hand, the left-hand side here. This is comparing overall survival of patients who got a transplant with the yellow line, and people who didn't get a transplant. And this is years of survival. And so if you get a transplant, you have a greater chance of survival. So there's a difference here, but it's not a huge difference. So that's a little bit disappointing, right? The second thing is that even with the transplant, there's cognitive decline or worsening. So again, this shows transplant in yellow, in non-transplant in this kind of greenish blue, in decades or years after the transplant. And so the transplant certainly slows or decreases the overall amount of cognitive decline as compared to people who didn't get a transplant. But as you can see, unfortunately, it does not completely cure that process. So even if we can't cure everybody, there's still a lot of treatment that we can do to help people. And that's a big point that I want to make today, is that there's things to make people's lives better, to improve family lives, to keep people out of the hospital, even if you don't have a cure. And so if you compare things that cause more healthcare burden or more costs compared to things that don't, some stuff, of course, costs a lot of money. So for example, getting a bone marrow transplant costs a lot of money. There's not much we can do about that, right? But there are things that we can avoid. So for example, needing to be in the intensive care unit. If we can avoid being in the intensive care unit, that's something that reduces, effects on the child and effects on health and effects on the family. Or getting an infection that leads you to be into the hospital. If we can avoid those infections, that can help keep you and your family and your loved ones out of the hospital. And so things that really affect outcome are like if you get an infection, if you have to be on a ventilator, if you have to be in the hospital. So anything we can do to avoid those things are good things. You think, well, how can we avoid infections? Well, sometimes it's fairly simple, straightforward things. So for example, people who didn't get an influenza vaccine were much more likely to be hospitalized with severe influenza or flu and need a ventilator. And so don't make sure every year you get your flu shot. Make sure you get your vaccine. So there's fairly straightforward steps that we can do that, even though they're not a cure for MLD or for other leukodystrophies, help keep us out of the hospital, help keep your kids out of the hospital. So just to kind of quickly summarize, at this time, bone marrow transplant is the only curative therapy, and it's not even fully curative. We have a lot of hope, though, and Dr. Wolf is going to talk about some of those really promising stuff coming for treating MLD patients. Another big issue is we need to diagnose earlier, and with the option for bone marrow transplant and these options for clinical trials and new treatments, we should be working on trying to get MLD added to the newborn screening so that we can be offering these treatments to families as soon as possible. And then the third big point is that even though we may not always be able to offer a cure, there's ways to make people's lives better. And these are sometimes fairly simple things by reducing infections and improving respiratory care for people who need those kind of treatments. So what are the kind of the next steps as we look towards the future? So one thing is newborn screening. It's a complicated process to get MLD added to a recommended list called the RUSP list, or the Recommended Uniform Screening Panel. That's something that the federal government releases for conditions they think need to be screened for. Even after the federal government adds it to the RUSP, each individual state has to add it to their individual screen, and that's a lot of work. At the University of Washington, Dr. Michael Gell has been working on a biochemical assay, and that looks really good for newborn screening. There's also a program going on in New York State and some associated institutions with Dr. Wasserstein with something called Screen Plus to see if that can help to prove that newborn screening helps in conditions like MLD. So I think that I'm really hopeful that over the next 5 years we can get MLD added to newborn screening, and that'll help a lot of families. The second major point for the future is that there are a lot of clinical trials going on for MLD. It's very exciting. There's an enzyme therapy treatment being trialed for the late infantile form. There's a gene therapy product being developed for improved bone marrow transplant, and there's also studies going on with in vivo gene therapy. And thanks for your attention, and we'll turn this over to Dr. Wolf. And Dr. Wolf, we can't hear you. You'll have to unmute there when you have a chance.
Thank you so much, Dr. Bonkowski, for that introduction to metachromatic leukodystrophy. And thank you for the invitation to present at the ULF. It's my first time at the ULF, and it's a bit strange because I don't see any of you, only Dr. Bonkowski at the screen. So my name is Nicole Wolf. I'm a child neurologist from Amsterdam in the Netherlands, and I'm working at the Amsterdam Leukodystrophy Center, which is part of the European Reference Network for Rare Disorders, rare neurological disorders. I've no relevant conflicts of interest for that talk. And our center has been founded by Professor Majo van der Knaap, whom many of you might know because she's coming every year to the ULF and has a huge record in leukodystrophies. And our center is actually, do you see this slide actually? Okay.
So we can see your first slide, and then it just shows us kind of the PowerPoint.
To see what's happening here, I'm sorry. Share screen, location window. Yes, okay, sorry. So our leukodystrophy center is a huge, well, not a huge, has a huge experience in working on leukodystrophies, and we actually work on several subjects: MRI analysis, definition of new leukodystrophies, identification of causal genes, natural history studies, histopathology, tissue studies of brain tissue, for example, understanding disease mechanisms, for example, with the induced pluripotent stem cells or iPS cells. Currently, what is very exciting and especially rewarding, we work on starting treatment trials for some leukodystrophies. We have mouse models for some of the disorders. And this is, of course, something we need more than 1 or 2 or 3 people. So that's most of our group, which consists of child neurologists, biochemists, electrophysiologists, stem cell biologists, and a lot of very motivated PhD students. And together we try to gain more knowledge about leukodystrophies. And metachromatic leukodystrophy is one of our main research domains since 2008. and we do research on treatment outcome, general management, including palliative management, neuropathy, mechanisms of the stem cell transplantation, and I will present some of those data later on. Biomarkers, which include MRI, MR spectroscopy, but also other tests. We work on genotype-phenotype correlation. That means how a certain DNA mistake actually causes that or that form of the disease. We are about to start a disease registry for metachromatic leukodystrophy, and we are also very pleased that we are able to collaborate with several other groups on this huge project of getting to know more about MLD. So that's actually the team of doctors and geneticists, MRI physicists working on metachromatic leukodystrophy, and Shanice, Daphne are PhD students who have as an exclusive task to work on certain aspects of MLD. So you might hear perhaps next year from them about their research. So in the Netherlands, we have a little bit a different situation from the rest of the world, although we are a very small country. We are about 17 million people and have about 170,000 births per year. So we actually estimated that we should have 4 to 5 patients per year, which would fit quite well with the incidence of Dr. Bonkowski. He just told you that it would be 1 in 40,000, and that's actually also what happens. We counted it for a 10-year period, and that's precisely what to expect. But in the Netherlands, we have actually less than a quarter of the late infantile form, which is everywhere else about half or even more than half of the patients. We have a huge proportion of juvenile patients and also adult patients. And I think the majority of our late infantile patients are of other ethnic origins than Dutch. So that has to do with the different mutational landscape in the Netherlands of the ARSA gene. And this is also something which actually makes it perhaps easier to do certain studies, but more difficult to do other studies in our place. So the setting in the Netherlands is, because we are a small country, that all Dutch patients with MLD are referred to the Amsterdam Leukodystrophy Center and usually seen within 1 week. And they're evaluated with a neurological examination, of course, a cognitive assessment, nerve conduction velocities, MRI and proton MR spectroscopy, gallbladder ultrasound, and blood testing. And about a third of cases, roughly speaking, are eligible for transplantation. And those are referred to another city, Utrecht, which is about 30 or 40 kilometers from Amsterdam, so not too far. And Dr. Lindemans, who is part of the MLD team, organizes and does the transplantation. We have also in the last couple of years referred 2 patients eligible for gene therapy to Milan for their trial. The neurological follow-up after transplantation is done in our center, and if not eligible for transplantation, we do the follow-up in Amsterdam, and also depending where the child lives, close to home with a general pediatrician. But the neurology follow-up is usually at our center. And if not eligible for transplantation, there is what I like to call active management. And that's also something Dr. Bonkowski has already alluded to, for example, to prevent respiratory infections, to prevent ICU admissions. That's certainly also part of our approach. We, in addition, actually have in the last 5-6 years now also performed more or less regular cholecystectomies. That means removal of the gallbladder, because most children with metachromatic leukodystrophy do have gallbladder abnormalities. You see here an echography of a gallbladder with a very thick wall that should be actually non-visible, and these gallbladder polyps, which can give a quite significant abdominal symptoms like pain and vomiting. So when we place a gastrostomy, we usually do at the same time a laparoscopic cholecystectomy. So that's a keyhole surgery, not very invasive and without significant complications so far. We also start quite early, certainly in children, with intrathecal baclofen treatment to prevent painful spasms and the severe spasticity many children have. And that's a small medication pump, which is placed under the skin, and that pump actually transports the antispastic medication directly in the cerebrospinal fluid around the myelum, and that actually eases spasticity. In adults, we do cholecystectomy when there are gallbladder abnormalities at ultrasound. Otherwise, we do regular checks. And also in adults, we treat the painful spasms with the intrathecal baclofen when indicated and perform gastrostomy when indicated. So I see in the comment that the camera locked up, so I try to stop that and to restart it. Okay. Our main research questions in the last years were what are good prognostic factors or markers predicting clinical course, including transplantation success? What are the long-term outcomes after transplantation? And that means outcomes after 10 years. And how exactly does transplantation work in the brain? And how exactly are the peripheral nerves affected? So when you see what prognostic factors in MLD are, it's certainly the brain MRI, involvement of white matter, the IQ at diagnosis, neurological examination, abnormalities at diagnosis, and also certain DNA mutations, and also brain proton spectroscopy. That's actually a test we quite like. With brain spectroscopy, you don't make photographs of the brain tissue, but you look at the levels of certain metabolites in the brain tissue. So that gives you an indication of how well the brain tissue works and about the integrity of the brain tissue. And here you see an MRI scan with a spectroscopy of a child with the early MLD and with the advanced MLD. And both children are at diagnosis. You see that this child has more white matter abnormalities than this child. And when you do the spectroscopy, and that's done in a very small part here in the more frontal white matter, you see that it looks really different from the child here. And especially that peak, which is NAA of N-acetyl aspartate, should actually even be higher than here, should be around here. But you see that in this more severely affected child, this peak is almost gone. Other peaks are relatively high, like this one or this one. And altogether, these peaks actually show us, especially this peak at diagnosis, what could be the outcome of the child in the next 2 years or so. So children who have a good or moderate outcome after transplantation have a relatively high, almost normal NAA peak, whereas the children with a poor outcome have a much, much, much lower NAA peak. So we use the height of that peak also for looking at eligibility of for transplantation. And that actually helps because it is a quite objective measurement, and and adds to other findings, for example, at findings at IQ testing or the normal brain MRI. Okay. Other good prognostic factors can be for part of the patients, not for all, certain DNA mutations. Some are associated with no or late and very mild motor involvement. So these patients have almost only cognitive involvement, and some are associated with no very mild peripheral neuropathy. Others lead to early and quite severe peripheral neuropathy. And what we also saw in the last year, that many children with other ethnic backgrounds have mutations which have not yet been described before. So we just have collected those data and wrote them up to have a good reference for also rare mutations. I already said that we are interested in how exactly transplantation works in the brain. How do the cells get into the brain, and what do they do there? Because when you successfully transplant a patient, an MRI can even improve. Like you see in that child, 4 years after transplantation, the white matter abnormalities have almost disappeared. That's actually something we didn't know 10 years ago. We always thought the transplantation could stabilize, but we wouldn't have expected that it could even improve white matter abnormalities. That's in selected patients, so only patients who are not too affected or even pre-symptomatic at diagnosis. In patients who are already severely affected, this improvement does not take place because the disease is progressing much too rapidly for that. So how do you do transplantation? You have your patient and you give a chemotherapy which is so intensive that you actually erase your own bone marrow. That's called myeloablative chemotherapy. So you are left without a functioning bone marrow. Without a transplantation, you would die because you wouldn't produce any blood platelets, any erythrocytes or white blood cells. With the donor hematopoietic stem cells, which are taken from bone marrow, cord, umbilical cord blood, or a peripheral blood, you can transplant those stem cells, and they actually produce and secrete the missing enzyme, the ASA, also in the brain, because these cells can migrate into the brain and make the enzyme there. So the previous theory, and Dr. Bonkowski already mentioned that term, was that these donor cells, or donor macrophages as we call them, are migrating through the blood vessels into the brain and produce there the enzyme, the arylsulfatase A, or ASA. And this enzyme is actually taken up by the nerve cells and also the myelin-producing cells, or oligodendrocytes, in the brain. And then do their work, actually digest the accumulated sulfatides and lead to a remyelination. So that was the idea. We are very grateful that we had a brain donation from 2 deceased MLD patients who had actually hematopoietic stem cell transplantation. And by that donation, we were able to compare their brains to untreated MLD patients. And we are very, very grateful to the families for this very generous donation. We usually do the autopsies in children with leukodystrophies within 4 to 6 hours after they died, which actually allows us to do quite intensive and detailed studies. And what we see actually in the brain tissue of the transplanted patients is that we do have the donor cells in the brain. And you see here cells which are violet, and cells which are smaller and brown. And these small brown cells are actually donor cells, which are producing the missing enzyme ASA and are able to digest the accumulated storage material. And therefore, those cells are also a bit smaller than the violet cells. With this staining, which is called oil red O, this shows also that these cells, the donor cells, are able to digest sulfatides. In a non-transplanted patient, you wouldn't see any red coloring here. There are also more myelin-producing cells, oligodendrocytes, which you can see here. That's a transplanted patient, and he has quite a lot of these brown dots compared to this untransplanted cell patient. And this means that there are more myelin-producing cells after transplantation, which actually also even produce myelin. That's a normal control. You see a very thick myelin sheath around that axon, that nerve axon. And in this transplanted patient, the myelin sheath is much thinner, but it's there. That's a typical sheet which comes from remyelination. They are always a bit smaller, a bit thinner than in healthy children. And what we also saw when we stain for other markers, that these donor cells are what we call anti-inflammatory or neuroprotective. They are much better for the myelin and also the nerve cells than the own patient cells, which actually induce a quite strong inflammatory reaction. So we think that the mechanism of the hematopoietic stem cell transplantation in metachromatic leukodystrophy is actually not cross-correction, but producing of the aryl sulfatase A enzyme, which is in the donor macrophages, which are able to actually clean up the storage material outside the oligodendrocytes or the neurons, and also produce factors which help oligodendrocytes to develop into fully myelinating cells. And that also explains that we see improvement of the MRI because the myelinating cells actually thrive much better and can develop into these myelin sheaths. What we still don't know is what are the long-term effects. Is there also storage, for example, in the neurons, which we are not able to solve so well with the bone marrow transplantation, as the enzyme is also not taken up by the neurons after transplantation. So that's something we are looking at the moment at, and also looking therefore at the clinical evolution in patients who had a bone marrow transplantation 10, 15, 20 years ago. I think we learn a lot from that as well. And there's also, I think when we better understand this, we might actually increase this anti-inflammatory mechanism and even help the oligodendrocytes more to remyelinate. That's something we will hopefully work on in the next 2 or 3 years. There are also new treatments. There is ex vivo gene therapy, which is still only in trial setting, but is already in the process of being registered as a treatment for metachromatic leukodystrophy for the early forms. It works a bit similar to hematopoietic stem cell transplantation. Actually, you take from a patient with MLD his own blood stem cells, and then from the bone marrow usually. And in the laboratory, you treat them with a virus to insert the ARSA gene, actually in a manner that the ARSA enzyme, the aryl sulfatase A, is even higher made than in normal people. Then you also give the chemotherapy, the very intensive chemotherapy. And after that, you give back the genetically modified hematopoietic stem cells, which then produce huge amounts of the enzyme and do that also in the brain where they migrate to. This treatment is, as the bone marrow transplantation from an unrelated donor, actually not helpful when a patient has already progressed significantly. We have now made also the experience that this step, the intensive chemotherapy, can actually even damage the brain. When we do a brain MRI 6 months or a year after transplantation, it always looks worse, quite significantly worse in most cases than the MRI before transplantation. And only after that time, you start seeing an improvement in those patients who are stable after transplantation. You can imagine that in a patient who already has significant white matter abnormalities, that this deterioration after the chemotherapy can be so severe that the patient will not be able to recover because even more of the brain has been damaged. So that's the reason why we want to select the children who go for this intensive treatment very carefully in order not to trigger a deterioration after the chemotherapy. So what have we learned in the last years? There are markers helping to decide whether or not it's too late for transplantation, and the MR spectroscopy is, in our eyes, a quite good marker. MLD has a lot of variants. You have heard about the late infantile, the juvenile, and the adult variants. That means a different age of onset. But we have also variants, especially in the juvenile and adult forms, where you have only mildly affected motor function and no or mild neuropathy. And during years, decades, only a cognitive decline like a dementia. And that depends on the variants, the mutations in the ARSA gene. And I hope that we learn more about that, because that will also help us better to understand the cause and also to tailor treatments. We also saw that the transplanted bone marrow cells are able to migrate to the brain and do produce aryl sulfatase A there, digest sulfatides, but this enzyme, the aryl sulfatase A, is not taken up by brain cells. The transplanted bone marrow cells have an anti-inflammatory neuroprotective appearance, and we think that this has an additional positive effect on the white matter of the brain after the transplantation. And we see in our patients who are successfully transplanted that there is some remyelination, that means some improvement of the white matter damage. And the long-term outcome after successful transplantation is still not clear, and that means neuropathy. There are many people who say the neuropathy does not improve after transplantation. There is no good research and no good literature about that. So one of our PhD students in our center is actually working on specifically that question. And there are also other problems after successful transplantation. One is that the ovaries are damaged in girls. So these girls actually develop, or women, young women, develop most of them an early menopause after the chemotherapy, so need hormone supplementation. But we also see in some patients a very slow neurological decline years after transplantation, although the white matter abnormalities are actually stable on the MRI. So that's something we are working on and hope to understand it better in the next years. So thank you for your attention. I would also like to thank all the patients and families who support our research, especially the families, the parents of the children who donated brain and nerve tissue for research, all colleagues around the world, also ELA, the European Leukodystrophy Association, for organizing MLD think tank. We met several times last year, and that was very helpful, and many, many others who help caring for these children. Thank you.
Dr. Wolf, that was a great talk. I feel like I've learned a lot.
Thank you.
All right, thank you so much to both of you. We do have a couple of questions coming from the YouTube end of things. We have a question on how often do you think adult patients are undiagnosed/misdiagnosed, increasing possibilities that adult rates are higher than believed?
So we certainly feel like we are not seeing as many adult patients as should exist by kind of number predictions. And the challenge is that for adult patients with behavioral problems like dementia or neuropsychiatric problems, that MLD is often not considered. And so first of all, often patients aren't getting an MRI. And second, when they are getting an MRI, sometimes the adult neurologists just aren't familiar with these diseases and aren't reaching out to folks with expertise in leukodystrophy. So we don't know the extent of the problem, but we feel like there is a problem.
Okay, thank you so much. And then one question that is directed just to you, Dr. Bonkowski, is Amy Price says she is familiar with your published research addressing racial and ethnic disparities in leukodystrophy diagnosis. Do you have any insights since that time on progress with these issues in both diagnosis and treatment access?
That's a great question. So it seems unfortunate, but the Black Lives Matter movement has really, in a way, helped push this to people's attention. And there's not changes that I can point to and say this is different or new. But I think between these publications, like from our group and from the entire society and medical community being aware, that is going to help, I think, with the disparities in diagnosis and treatment. I think another big thing that I would like to point out that's going to help is with newborn screening, it takes away the barriers to diagnosis that often exist. So for example, with ALD and newborn screening, I think we're going to find a lot more people that were never even considered who probably have ALD running in their families. For example, like from Hispanic families or African-American families. And then I think the same thing will happen, I hope, in a few years with MLD, where we'll really start to be able to help families faster, sooner.
Great, thank you so much. And Dr. Bonkowski, I know you said you had to run, so feel free to just say goodbye whenever you need to. But we do have a couple of more questions. So Dr. Wolf, if you'd like to try to cover these, we have one that says, is bone marrow transplant available for adult patients?
Yes, it is available for adult patients. We use not the identical but similar criteria for younger children, although we are more liberal with, for example, IQ, because the progression in most adult patients is much slower. But I have to say that the results are not, how should I put that, not overly optimistic, because the biggest problem in adult patients is the cognitive deterioration, and that isn't at least not reversed, and we sometimes think not even stabilized. It goes perhaps slower than without transplantation. So that's something we have to do really more research on.
Great. Okay. And then it says the frequency of MLD in the Netherlands is, you said, 1 in 40,000. Is the frequency thought to be similar in the rest of Europe and in the USA?
Yeah, for the USA, Dr. Bonkowski has presented the data, and that's very similar. And for the rest of Europe, globally speaking, as well. Okay.
And then I've put last call out for questions on the YouTube side, but we do have one more that I see right now. And excuse me if I say this, butcher these words. What percentage of patients are you placing intrathecal baclofen pumps?
Yeah. Actually, in the meantime, it's almost all patients who haven't had a bone marrow transplantation and are deteriorating motor-wise, so that they have a significant spasticity. They will more or less get baclofen pumps, with the exception, and these are the very small children with the late infantile form, because they are sometimes a bit too small to place this pump.
Okay.
We also placed this pump in adult patients. I remember one adult patient who had been wheelchair dependent and had severe spasticity for years, and had to be admitted every couple of months to the hospital with a severe spasticity, sweating, pain, and needed a lot of medication to get him through that. And after he got his baclofen pump, that completely stopped. He never had to go to hospital again, and actually gained 10 kilograms of weight with the same amount of feeding, because this severe stiffness, muscle stiffness, also burns a lot of calories. So the baclofen is a treatment which is, in our opinion, really very important for the quality of life of the patients.
All right, great. Thank you so much for your time, Dr. Wolf. And Dr. Bonkowski did have to run, so he's already signed off, but it doesn't look like we have any more questions coming through on the YouTube end. If there is anybody out there that does have any additional questions for Dr. Wolf or Dr. Bonkowski, feel free to email us at theoffice@ulf.org. We will pass along those questions and do our best to get answers back to you. But in the meantime, thank you so much for your time, Dr. Wolf. And thank you to everyone watching, and hopefully we will get to see everyone next year in person in Chicago.
Thank you so much, and apologies about the video.
No worries. Thank you so much, Dr. Wolf.